Well, hello, everybody. My name is Babette Renneberg. I'm a professor of clinical psychology and psychotherapy at Freie Universität in Berlin, Germany. And I am currently the president of the European Society for the Study of Personality Disorders, the ESSPD. And on behalf of the ESSPD, I'd like to welcome you all to our first webinar with the topic euthanasia and medical assistance in dying in patients with personality disorders. We as ESSPD have published an article on this topic, and you can find this on the website. And today's discussion was originally planned to take place in Antwerp, Belgium in September of 2022. Due to the pandemic, we had to postpone the conference, which will now be held in October of 2022, and of course it should be 2020 that we held it. And at ESSPD, we think the topic of euthanasia is timely, and we would like and decided to learn more about this controversial issue and discuss the current knowledge from a European perspective in a webinar which is taking place today. We were able to invite experts on the topic from 4 different European countries who will present today their perspective. And for your information, we had 500 places available for this event, and it is almost this number of colleagues who have registered today. Now, I'd like to introduce my colleague, Christian Schmahl. He is professor at the Institute of Mental Health in Mannheim, Germany, and he will be the moderator of our event and will lead us through the program. Welcome, Christian.
Yeah, thank you, Babette, for the introduction, and welcome to all of you to this webinar. I'm really glad that this takes place today and that I can lead you through the program. As Babette already mentioned, euthanasia and assisted suicide are very important and also controversial topics. And over the last 2 decades, an increasing number of countries, including the Netherlands and Belgium, have legalized euthanasia and physician-assisted suicide. And this has led to a considerable debate over the problems and dilemmas. Particularly, an increasing number of people with personality disorders that are faced with unbearable suffering have requested and received assistance in terminating their lives. However, this issue has received very sparse attention from clinicians and researchers, at least in other countries in Europe. So this event is therefore devoted to informing you and the European community that is interested in personality disorders about this topic. And I'm very glad that we have 4 very distinguished presenters from 4 different European countries, Italy, Belgium, the Netherlands, and Norway, that will present their views and also very important information about EAS in their respective countries. As already mentioned, we have these 4 presentations, and this will be followed by a audience discussion session. And since we are nearly 500 people, we can't have you talk, each of you. So we will have the question function, and you see in the webinar, please use the question function to write in your questions, and also please name the person the question is addressed to. If you have a question for one of the presenters, please name the respective person. We will also record this webinar and make it later available at the ESSPD website. but for this recording, only the speakers and the presentations will be seen. So no one from the audience will be seen in this recording. Okay, so we will now start with the first presentation, which is by Ester di Giacomo from Milan, Italy. And just a brief introduction. Ester is a MD PhD, and she's a psychiatrist at a medical institution, mental health hospital in Monza, Italy, and also a researcher in neuroscience at the University of Milan Bicocca. And her fields of interest are personality disorders, forensic and perinatal psychiatry. And she received several awards and also is a psychiatric member of the American Academy of Psychoanalysis and Dynamic Psychiatry, and has been elected the representative of the ESSPD Young Researchers. And she will introduce the issue and the topic of euthanasia and assisted suicide with a view on psychiatric patients. Ester, please, the stage is yours.
Thank you very much. Good afternoon, dear colleagues. I'm very happy to be here, and I'm happy and delighted many of you could participate to this important webinar. I want to thank you, the organizer, for inviting me, because this sensitive issue is crucial in our debate. My role today is to introduce you to the issue of euthanasia and assisted suicide for the legislation and a particular view on psychiatric patients. I have no conflict of interest to disclose. Starting from the definition of euthanasia, it derives from the Greek and it means good death. Practically, it is the practice of intentionally ending the life to relieve pain and suffering. A modern definition was given by Denys, and he said that euthanasia means that the physician acts directly to end the patient's life, for example, giving a lethal injection. In contrast, we have the physician-assisted suicide, which is the situation, and it means when the physician provides a specific means and instruction to a patient with the intention of ending the patient's life, but is the patient himself that performs the act of ending his own life. Historically, starting from Hippocrates, any kind of assisted dying was explicitly forbidden, as it was also in the medieval period and in the early modern age. But at the beginning of the 16th century arose the concept of mercy killing that was openly discussed and supported by some philosophers and ethicists. Which are the issues we will discuss today? The legality, legislation, morality, and if euthanasia is only for physical illness. Legality. It is legal in some countries with strict rules, while it is absolutely forbidden in other countries. This is the European situation. We can see that euthanasia is legal in the Benelux countries, so Belgium, the Netherlands, and Luxembourg, while in Switzerland and Sweden, it is forbidden, but it is authorized the physician-assisted suicide. In Spain, France, Austria, Germany, Denmark, Norway, it is forbidden, but it's authorized as allow a sort of help to die that is called passive euthanasia, by means of the withdrawal of life support to patients who explicitly request euthanasia. In Portugal, it is forbidden both euthanasia and assisted suicide, but in some particular cases is authorized to stop heavy treatments that are too strong, their burden is too strong for the patient. While in Italy, Ireland, Poland, Romania is absolutely forbidden any kind of assisted diet. Legislation. This is a brief summary of the legislation in the country where euthanasia is allowed, but they will cover it by expert colleagues after my presentation because they are more expert than me and they practice in these specific countries. Switzerland was the first European country to legalize physician-assisted suicide in 1942, but not euthanasia. However, according to their legal practice, euthanasia is not punished if it is delivered free of selfish motivation. In Germany, we had an advancement about a year ago, because in February 2020, the Federal Constitutional Court, which is the Germany highest court, overturned the ban on organized assisted suicide, practically declaring the right to die, that the right to die includes the freedom to rely on the help of someone else, on the voluntary help of someone else, obviously. I wanted to give you a brief in-depth analysis about my country, because in my country, Italy, it is absolutely forbidden, but the debate increases, especially after some crucial events. The first one was the death of Pier Giorgio Welby. Pier Giorgio Welby was a political activist of the association Luca Coscioni, which is an association that fights for the right of self-determination in terms of termination of life, reproduction, and so on. He was affected by myasthenia gravis and asked to, in the last year of his life, he asked to avoid resuscitation. When he died, his doctor has to face a trial because he was accused of murder of consenting, according to this article of the Italian Penal Code. The second case was that of Eluana Englaro. She was a woman who had a car accident, and after a period of coma, she remained in a vegetable state. And after about 10 years of vegetable state, her father explicitly asked to stop hydration and food support. And there were many political consultations to be authorized, but even after authorization, her father was accused of murder. She was judged innocent, but he had to face a trial. The last one was the Cappato trial, because Marco Cappato was an activist from the same association of Pier Giorgio Welby, the association Luca Coscioni, and this guy you see in the picture, whose name is Fabio, who had a car accident and remained tetraplegic and blind, to reach Switzerland, where he had physician-assisted suicide, biting a button with a little injection, a little substance. And Marco Cappato was accused of help in suicide, according to this other article of the Italian Penal Code. After about 2 years of trial, he was judged innocent because the case doesn't exist. Another issue is the morality of euthanasia, because the debate worldwide, and a part of this debate is the religious part, and this is particularly heavy in Italy because, as you can see in this advertisement, there are protesters all around the world. But if you see on the top, on the left top of my page, the Catholic part say euthanasia is an homicide. And I think the central pick is even more crucial because it appeared in Italy about 2 years ago, and they play on the sense of guilty and use mental illness to make the lever on that, because that advertisement say Marta, she's 24 and she has anorexia. She could ask to be killed. What about if she's your sister? This is the sense of guilty. Part of my presentation is focused on psychiatric illnesses and especially on personality disorder, because if physician-assisted suicide or euthanasia were originally intended to facilitate death without pain, suffering from physical illness, people with mental illness have gradually been considered eligible. The first important case that arose media attention worldwide was that of Aurelia Brauer's from the Netherlands, because she asked for euthanasia and she was permitted to have it, but she hadn't a diagnosis of a terminal medical condition. The second was that of Noah. Noah, this is a particular case for me because I was asked to comment about her case for Italy. So I will see a little later. And she was repeatedly raped and developed post-traumatic stress disorder, depression, and anorexia. She asked for euthanasia, but she was denied. So she had passive euthanasia and died at home from starvation. On the left, you can see my article about the reason that could lead Noah to ask for that. But on the other part, we have the comment, the direct comment from the Pope that said that that was not a suicide, but the case of Noah was euthanasia. So some legislations opens to psychiatric patients because they allow euthanasia even for patients who are not expected to die within the foreseeable future. And this is the case of psychiatric patients. You have to attest to their mental competence based on their cognitive competencies, the ability to make and communicate personal choices, the ability to comprehend the information provided, the ability to apply that information to your own context and situation, and the ability to reason and deliberate. Any request must be accompanied by appropriate emotions, and in this respect, ambivalence has not to be seen as a symptom of reduced mental competence, but as a possible logical consequence of the fear of death. And moreover, it could be a lever to ask the patient to focus again on exploring options of recovery or rehabilitation. It has to be a well-considered request, and this means that the patient has to be well informed by his physician regarding her psychopathology, possible ways to treat and alleviate his suffering or her suffering, side effects from the available treatment you offer them, and his prognosis with and without treatment. The specific issues in psychiatric disorder, if they are really untreatable, the patient mental competence, because sometimes it could be affected by the mental illness, the requirement for psychiatric disorder to be uncurable, and this might be difficult to attest because the symptoms of mental disorder fluctuate, so they tend to change over time. The requirement of a well-considered nature of the request, and this is difficult too because that wish might be a symptom of the mental illness, and the unbearability of the suffering. And here we have a lack because we don't have an effective assessment instrument to assess this unbearability. And lastly, sometimes the patient has a reduced awareness of his own illness. Especially true for personality disorder. First of all, we have to say that personality disorder are the most frequent diagnoses for patients who request euthanasia under the age of 60. And for the most common personality disorder, so I mean borderline and narcissistic, the wish for that is strictly linked to the pathology, because, for example, for borderline, they have emotional and behavioral dysregulation that is closely linked to suicidal behavior, and this is also linked to the difficulty in regulating relationship that can lead to emotional instability. On the other hand, for narcissistic personality disorder, they have a hypersensitivity to the evaluation of the other, so their self-esteem fluctuates from grandiosity to a depleted state, which is very close to self-threatening behavior. On the other hand, we have a lot of treatment we can offer our patients because we have several kinds of psychotherapies that we know may help them, and we have pharmacological options. The last part I want to offer you is a little help we can learn from philosophy, so from another discipline, because I think that in the specific case of psychiatric patients and personality disorder in particular, we need a little help. I report here some part of a paper from philosophers you can see in the references, because they reflected on voluntarity of action. So an action to be voluntary has to be an expression of the person's character, and this means self-determination and self-governance. So an action is self-determined if the person's character is the source of the action, while it's governed if the person's character endorses the action. Second, is voluntary if it occurs for an intelligible reason, and third, if it is possible for that person to act otherwise. So from a descriptive ontology point of view, and this is specific for personality disorder, the wish to die must be classified as a symptom, for example, of borderline personality disorder. And this is very close to the definition from the DSM-5 and ICD-10, because DSM-5 says that personality disorder is stable across time and consistent across situation, while for the ICD-10 is a severe disturbance in the characterological constitution and behavioral tendencies of that individual. But these definitions preclude the possibility of dissociating a person's wish to die from the person's mental disorder, for example, in borderline personality disorder. And the conclusion is that the wish to die inevitably influenced by the mental disorder, because the mental disorder pervades the person's character. But the inability to dissociate the person from the personality disorder from the person's character means that that action, that request, is reflective of the person's motivation. So we have to pay attention and to demonstrate independently that that request and that person lack of an intelligible reason to ask to die and couldn't have chosen otherwise. Thank you very much for your attention.
Yeah, thank you very much, Esther, for this great overview and the introduction to this issue and topic. And I just I wanted to apologize for the fact that your video was frozen. We could all hear you, and but your I think for most of us it was frozen. It may be related to the internet connection. So, but we could all see your slides and could all listen to your presentation. I
Okay,
also
so you don't see me gesticulate like all the Italians.
I think that was fine. Just to remind maybe those that came later, for the question and answer session at the end, please use in the window for the questions and write in the questions for the presenters, and also name the presenter you are asking. so that we can moderate the question and answer session at the end. All right, so we move on with the next presentation, who is by Joris Vandenberghe from Leuven University. And let me just briefly introduce Joris. He's a psychiatrist and a psychotherapist in biomedical sciences. And he works at Leuven University Psychiatric Center and at the Leuven University Hospitals. And he's really an expert in the field of euthanasia. He, as a liaison psychiatrist, is often involved in the evaluation and the care for patients requesting euthanasia, as well as in the general hospital, as in the psychiatric in an outpatient clinic. And his research interests also pertain to clinical liaison psychiatry and ethical and judicial aspects of psychiatric care. And as a board member of the Flemish Association of Psychiatry, he co-presides its working group on euthanasia and co-authored its guideline on euthanasia. So he's really the expert in Belgium on this issue. And he also founded last year a walk-in house in Leuven called Reakiro, and an outpatient center especially for patients with a euthanasia request. So please welcome Joris, and the stage is yours.
Thank you, Christian. I hope technically you can see my slides now and you can all hear me. Good afternoon. Thank you for having me here over for this lecture. I would like to give you in 20 minutes an impression of the state of the art of euthanasia in psychiatry in Belgium. I'll mainly focus on, and try to get to my next slide. Yeah. I'll first shortly, as you've heard before, I have a disclosure to make, no financial conflict of interest, but I'm involved in euthanasia in several ways, as you can see here. What I would like to discuss with you is first the legal framework in Belgium, give you some details because that's important to understand, especially the application in psychiatry. Then I want to focus on the situation in psychiatry. I want to give you some data on the euthanasia practice since the legislation is in place since 2002, focus on some problems with Belgian practice, especially in psychiatry, and those problems have, were the reason that there were some guidelines and advices formulated last years, and I would try to give you a brief impression of what these guidelines are saying. And I would like to end with a conclusion on the paradox I often meet in evaluating patients with euthanasia requests. To be brief on the legal framework, there's a clear framework for euthanasia, but not for physician-assisted suicide. There is a controversial interpretation that it is possible as a kind of form of euthanasia, but especially from a legal point of view, that's highly controversial, and it's debated in Belgium whether we can actually proceed with physician-assisted suicide. I'll focus on euthanasia because that's a clear situation. It is defined in our law as deliberately ending the life of a patient by a physician at the patient's request. So by definition, it's active and it's voluntary. So that means that in our understanding, in the way the concept is defined in our legislation, there is no place for concepts like passive euthanasia or involuntary euthanasia. Those are contradictions in terminis, so that doesn't make sense according to the definition that is used here. It is an exemption legislation. That means that in Belgium, it still is a crime only when certain criteria are fulfilled. It is not considered a crime. So it's really an exception. And of course, everyone is free to participate in euthanasia in one way or another. Every doctor has freedom of conscience to be involved or not be involved. I will focus on the actual euthanasia request. I mean, a patient asking for euthanasia in the near future. That is different from the advance request. The advance request is also possible in Belgium, but only for irreversible coma, so not relevant in the context of psychiatry. So what are the criteria that are in our legislation? Well, for starters, the request has to be voluntary, well considered, deliberate, and repeated. And as already discussed by Esther, this implies competence, this implies specific decision-making capacity. And one of the elements is that, of course, the death wish is not merely a symptom of the disorder. The law also states that there can't be any pressure, any external pressure whatsoever. And the crucial part of our legislation is the sentence that the patient is in a medically hopeless situation of irremediable, unbearable, and continuous suffering. caused by a severe and incurable illness for which treatment has become futile. And you can notice that in this sentence there are a subjective aspect, the aspect of suffering, that is mainly the appreciation of the patient, but there's also a more objective part in it, and that is the appreciation and the evaluation of the physician involved. You should demonstrate that the situation is hopeless from a medical point of view, so that doesn't rely upon the feelings of hopelessness of the patient. It is irremediable, the illness is incurable, and all treatment has become futile. I'll focus more on these elements in the next part of the presentation. I'll be brief about the other elements. This is the core element, of course, and this has been partially discussed by Esther. The patient has been informed about several aspects. The request has to be written. The evaluation is a whole process and not just one moment of evaluation. You have to involve the nursing team if the patient wishes, so you also involve the next of kin and the friends chosen by the patient. And importantly, you can never decide this on your own as a physician. You have to ask the advice of an independent colleague with relevant competence. And that colleague has also to see the patient and to give written advice. Everything has to be documented in the medical file. And there are some extra due care criteria if the patient is not in a terminal phase, which is, as a rule, the case in psychiatric illness. Then you have to ask another doctor, so it's a third physician involved, a second independent colleague, and the law states that this should be a psychiatrist or a specialist in the illness. This means for psychiatric illness, it has to be a psychiatrist, and there should be at least 1 month between the request and between euthanasia for all patients who are not in the terminal phase of their illness. There is also a new possibility, well, more recently in 2014, the law was changed and for the possibility of euthanasia in minors, but in a very limited way, only for competent minors, as formally assessed, only if the legal representatives agree, only in physical suffering, or only in the terminal stage. So this has no implication for psychiatric illness. Just to summarize, what are the grounding principles for this legislation? Well, of course, it has all to do with autonomy in the end-of-life decision-making in a medical context, because the law is quite clear that the suffering should be caused by an illness. So this is not because someone is lonely or feels that he's tired of living. It should really be a medical cause for the suffering, and for which treatment has become futile. So the logic is really this last resort. You should first be given the chance to reduce suffering by all means available by modern medicine and by psychiatry or mental health care if it's about a psychiatric illness. Importantly, it's also integrated in palliative care. This is not something on its own in Belgium. This is really part of a whole integral approach of palliative care, where euthanasia is one of the options integrated there. So that brings me to the second part. We will focus on psychiatric suffering, suffering caused by psychiatric illness. And to be brief, we can say that psychiatric illness as a cause of the suffering is not excluded in the law. There's a lot of discussion whether it was really intended for that, a lot of different interpretations, but certainly it's not limited to physical suffering, and the suffering can be caused by psychiatric illness to the extent that, of course, the difficult topic said that the specific decision-making capacity is sufficiently intact and can be established, and that you can demonstrate that the illness is irremediable, that there's no more reasonable treatment option. In other words, there's a lack of prospect from a medical perspective. Interestingly, in the same year as our euthanasia legislation, there was also our patient rights law, and there was a clear discussion on should we have a different set of rights for patients with a psychiatric illness, and it was clearly chosen not to do so, and happily so. I think one wanted to avoid discrimination and stigma, and in the same parliament, this law, this euthanasia, was voted in the same year, so one can imagine that these elements might have played a role as well. But of course, there's no specific approach or no specific criteria for patients with psychiatric illness, so you could argue that maybe there is a mismatch between the legal approach and the legal criteria and the specific problems that arise in psychiatric illness. So just to give you some figures and give you an idea of how things are evolving in Belgium in the over 18 years we've had this legislation. Here you see the number of euthanasias all taken together, and the large majority of them are patients in the terminal stage of their life or terminal stage of their illness. And you can see a steady rise. The last year we have data from 2019, we were over 2,500 we had over 2,500 euthanasias. I'll now focus on a subgroup of this large group, namely the group with patients that are not in a terminal phase. As a mean, it's about 13% of the previous group, but the proportion is rising. We see that the proportion of patients in the last year we have data from is 17%. So the figures here are much lower, and now I'll focus on another subgroup of this subgroup, namely the patients with psychiatric illness, which as a rule are not in a terminal phase of their illness. Data are more difficult to interpret, so I combined some different sources here, but I think this is pretty accurate to have an image of the evolution of the numbers of patients who died through euthanasia because of psychiatric illness, because of unbearable suffering from psychiatric illness. And you see that in the beginning of the legislation, it was almost not present in the data. It started to rise around 2011, 2012. And in this period, one was really worried what is happening in Belgium. These are data that were quite high, about 50 patients a year in the year with the highest number, and which were rising for a few years. But since 2013, the figures seem to stabilize or even lower a bit. So the rise that was feared was certainly not continued. And if you look at the mean number of euthanasias due to psychiatric reasons, we're talking about 29 patients a year, which is 1.7% of all euthanasias in Belgium. And then, of course, I want to focus on the diagnosis of this subgroup of patients with psychiatric illness. But I have to say, and this is a general problem in Belgium, we have often poor data quality on aggregated data. Diagnosis is not reported in a structured way. It's a post hoc interpretation. But what we can say is that with the limited data we have, that mood disorder certainly is the largest group. In some data sets, up to 80%, mainly unipolar, some bipolar depression, with or without psychiatric comorbidity, which I guess is quite high, but which is not well documented. I'll give you some examples. Here you see a study which also includes dementia. So ignore the last row here, the last column here. That's not relevant for today, and that means that the percentages are not relevant either because they look at the total group. But it's just to give you an idea that the most important group is mood disorders, and even combined with the mood disorders with comorbidity, we are looking at about 80% of all patients who have at least a mood disorder, and sometimes in a smaller group another disorder present. And to give you an idea of the sex ratio, it's mainly female patients for every of those groups, and the age distribution is the whole age range is represented. They're not evenly split up, but you see a group 80 and older although it's a small group, you wouldn't expect that much people, is quite well represented here in the euthanasia figures. These are more recent data, that have come out since the previous figure of the paper I showed you, and you see the same pattern, mainly mood disorders. This is the mood disorders. Ignore this part. These are the dementias, not the topic of today. And then, interestingly for today, I want to focus as well on the personality disorders with the same limitation of the quality of data, which is low. And one could say that here in the complex combination of different psychiatric illnesses, maybe personality disorder is present as well. But as you see, it's a very small group. I think the comorbidity is much higher, but it's not well documented. But just to show you that the group that was officially classified as personality disorders is a quite small group. There was 1 year, 2014, where there were 12 patients. All other years were much lower numbers of patients that died through euthanasia because of suffering from a personality disorder. These were the euthanasias. Now I want to focus on the euthanasia requests. The euthanasia requests because of psychiatric illness. Again, the data problem. We have no overall data. There's no central registration of all the requests. We know that it's much more than the actual euthanasias. And we only have one scientific publication describing 100 patients with a request. It's coming from a very active group, which also has a quite liberal view on euthanasia. And they describe that comorbidity is the rule in the patients requesting euthanasia. More than 90% has more than one disorder. And the most frequent diagnosis here as well is depression. But personality disorders is much higher than in the euthanasias. including 29% who have a comorbidity of depression and personality disorder. So one could interpret this data that there are a lot of patients with personality disorder applying for euthanasia or requesting euthanasia, but the actual euthanasias, it's a very small group. So the large majority requesting euthanasia with a personality disorder is not really granted or is not finally choosing for euthanasia. But that's an interpretation. The data are, as I said before, quite limited. In this group, less than half, a bit less than half of the requests were accepted. But as you can see, not every patient who has his request accepted also carries on with euthanasia. Only 35 here carried out, was a euthanasia carried out. And another impression of the age and sex ratio or distribution in this group, again, you see mainly more than 2/3 are women. And you see a distribution over the age range, which is more even here than in the actual euthanasias. Okay, then I want to focus on the problems of the Belgian euthanasia practice, especially in psychiatric suffering. There's a huge controversy on this topic in Belgium as well, and internationally the same, I think. There's one recent study showing that 75% of the psychiatrists agree with maintaining the legal option of euthanasia in psychiatry, but a group that is almost as big is really questioning the approaches taken by other physicians. So one agrees that it should be a legal possibility, but the way it is dealt with now is questioned by a large majority of the Belgian psychiatrists. And only a small part of the psychiatrists is really prepared to play a formal role in euthanasia. For me, this is a crucial slide because it summarizes one of the crucial problems in the euthanasia in psychiatry, namely the variability and the subjectivity in interpreting and assessing the legal criteria. The legal framework doesn't specify how you should judge decision-making capacity, what irremediability and futility means, how to deal with treatment refusal. And this is causing a lot of problems, or was at least causing a lot of problems. In fact, a single physician decides. He or she has to ask the advice of two colleagues, but that advice is, strictly speaking, non-binding, and there are no specific criteria for determining which reasonable treatments have to be tried before euthanasia can become an option. And there's no multidisciplinary review obliged or case discussion obliged in the procedure. There's a lot of criticism on the control mechanisms. There is a Belgian Control and Evaluation Committee, but it is hugely criticized in their methodology, in the way they judge information, the very limited information they get. So that's a problem in Belgium, I think. And there was last year a euthanasia case in court where 3 physicians, 1 psychiatrist, were charged with poisoning. So actually murder by given poison. So that's the judicial qualification if euthanasia is not according to the legal criteria. No one was convicted, but it was highly mediatized, and there was a huge debate for weeks in the media on the topic of psychiatric euthanasia. Because of all these problems, I and many other colleagues have publicly argued for a stricter approach and development of professional and ethical guidelines and advices. And here you see a newspaper title, and we have to raise the bar for euthanasia in psychiatry. That's the general gist of the discussion that was in the media for quite some time then. And that brings me to the last part before I want to conclude. The professional and ethical guidelines were actually developed. The last few years we had a huge effort in several organizations developing guidelines specifically for euthanasia requests because of psychiatric illness. And all of these guidelines, in fact, say that the law is not sufficient. We need due diligence, extra criteria, extra elements in the evaluation procedure for this specific group. And I will not go into detail on the different guidelines and advices and position statements that are available. Some of them are more binding than others. But I want to focus on some general aspects overarching the different guidelines. First, I want to give you an idea of the scope of the guidelines. All of them acknowledge the difficulties and the complexity of euthanasia in psychiatry. Some of the topics have been discussed. Ester has touched upon them. But the general idea is that we don't see them as a reason for excluding patients with psychiatric illness, rather a reason for a rigorous assessment for due diligence and for extra due care criteria. So that's the general idea of the guidelines, and I want to focus on 3 points. The fourth is just to point out that there is much more in these guidelines, but 3 general points is that all of them focus on the no reasonable alternative criterion. How do we establish that there really is futility, that the psychiatric condition is irremediable and the suffering is irremediable? They focus on the way we have to evaluate it, the evaluation process, and they focus on what we call a 2-track approach. That besides and parallel with the evaluation, we always have to focus on the recovery-oriented continuation or reinstallation of care. I'll discuss 1, 2, and 3 briefly to give you an idea what is moving in the field of euthanasia here in Belgium. So the no reasonable alternative criterion or futility in fact means that there's a lack of reasonable treatment options or interventions. Nothing can be done for reducing suffering, and it is assessed that the chances of spontaneous improvement are extremely low. And the plea of all these guidelines is that this has to be based on a medical assessment, strictly adhering to diagnosis specific evidence-based standards. That's the idea. You first have to see what are the evidence-based treatments for this diagnosis, and have all of them been tried in a judicial and professional way. Guarantee that every intervention has been tried according to the state of the art, and of course this has nothing to do with the patient's judgment. This is really a medical judgment, and this has implications for refusal of treatment, because of course if a patient refuses a treatment, then you cannot establish futility or irremediability. So it can only be irremediable if the patient had not refused a reasonable treatment option. So they all plea for an elaborate exploration and evaluation process, focusing on all the criteria, but also a psychotherapeutic exploration of the pressures that might be possible, the layers of meaning of the request. And they all stress that the process should consist of several contacts of a lot of time. Some even say at least 1 year for evaluating the euthanasia request, requiring a careful consideration of the patient's context via social perspective. At least 2 psychiatrists should be involved, and more than the law asks. Positive advice is needed, and not just an advice. It should be positive. Specific expertise should be sought for the different elements. Consultation and discussion among all people involved, all professionals involved, are imperative. So this is the elaborate process, focusing that in fact it's more than just a checklist, and all opportunities provided by the evaluation process should be taken by the clinicians, and they should focus on the recovery to reduce suffering and to reorient patients to life. And then there's the imperative 2-track approach. That means that we have to continue, or in some cases restart, because sometimes the patient consults us and is not in care anymore. We should continue or restart recovery-oriented care in parallel with exploration and evaluation of the request. So that implies we don't give up on patients, and we keep supporting them, we keep offering them care, we keep striving for a meaningful life and positive sense of identity despite the psychiatric illness. And to end my presentation, I'll leave out the part on, I wanted to stress, and you can read the slides if you're interested in that part. But the bottom line here is in the guidelines, we have to use the evaluation process by giving it ample time and contact, by involving family and important third parties. This is not just a choice of a patient. We say that this is necessary to have a thorough evaluation. And then I just listed, and I'm not going to talk about all these questions, but to give you an idea what are the topics that we are tackling in such an evaluation process. Well, we have to answer a lot of questions about diagnosis, about comorbidity, about all the treatments that have to be tried. Have they been tried in a good way, in a recovery-oriented way, about patients' competence and decision-making capacity, and so on, about transference, counter-transference, ambivalence. So this is a lot of work to be done. I can't imagine you doing this in a few sessions. You need 10 or more sessions at least to get a reasonable answer on all the questions I just listed here. Okay, because of time, I'll end here my presentation, and I'll just invite you to read about a few more slides I prepared on the paradox we often meet in euthanasia requests. Thank you for your attention.
Thank you, Joris. This was a very informative and fantastic overview. And I think we will definitely have time at the end. So please, again, make use of the question function. So write in your questions if you have questions to Joris or to the other presenters. Please feel free to write them in. I see the questions coming in right now already. And we now move on from Belgium to the neighboring country, the Netherlands. And the next presentation will be given by Damiaan Denys. Let me also briefly introduce him. Damiaan is a professor of psychiatry, and since 2007, he's the chair of the Department of Psychiatry at the AMC, the Academic Medical Center in Amsterdam, the Netherlands. And he is a well-known expert on psychiatric research, particularly in the field of anxiety, impulsive and compulsive disorders. And he's taken a translational approach and makes use of different disciplines, including clinical psychiatry, neuroscience, and philosophy. And a particular focus of his research is development of high-end treatment strategies such as deep brain stimulation for psychiatric disorders. And he has pioneered this field in the field of OCD, depression, addiction, and eating disorders. So now, Damiaan, please, the stage is yours, and we're looking forward to your presentation.
Okay, thank you. Thank you for the introduction. I'm glad to be here and have the opportunity to present some of the material from the Netherlands. There is some overlap, unfortunately, between Belgium and the Netherlands, at least regarding euthanasia. There are also a lot of differences. So apologies beforehand if there are too many, or if there is too much overlap. Just to start with a small overview, I think euthanasia is now legal in 7 countries out of 195, depends how you calculate them. It was legal in the Netherlands in 2002. And well, the idea was that it should be legalized because of 2 main reasons: provide legal security, assuring prudent practice in case people want to commit or use or request for euthanasia, and provide an adequate framework with societal control. The criteria for euthanasia were developed at that time based on a few conditions. It needed to be a voluntary and well-considered request in the presence of an unbearable and prospectless suffering of a disorder, and the absence of reasonable treatment options. These were the 3 main criteria for legalizing euthanasia. The idea why it should be legalized in the Netherlands was based on 2 major principles. The first principle is the principle of compassion. It was the idea that humanity in general, or the Dutch population, should counteract unbearable suffering. And the second ethical principle is the principle of autonomy, the right of self-determination. And the Netherlands is a quite liberal country. I show you here beneath what the idea was of the Dutch population regarding euthanasia. So there was a recent enquête made in the Netherlands where people were asked what their ideas were about euthanasia. As you can see, 5 out of 10 people in the Netherlands, citizens, think that patients with psychiatric illness should get euthanasia if they request it. 6 out of 10 would allow it for patients with dementia, 4 out of 10 for healthy people with their life completed. So in the Netherlands, there is a concept, it's called the completed life concept. There is a political party, and they plea for acceptance of euthanasia based on your own idea that your life is completed, regardless of any suffering or disorder. And then finally, 4 out of 10 think that children younger than the age of 12 should as well may undergo euthanasia if requested. To put it right, the Netherlands is, I mean, a very liberal country, but and there is sometimes misunderstanding. It is not a duty and not a right. So doctors are not obliged to perform euthanasia, and patients have no right to euthanasia. The decision is actually based on a joint decision of both the doctor and patient. And at any time, a doctor has the freedom to invoke conscious objections. He can refer a patient to a colleague, someone else, but strictly speaking, there is no obligation for a doctor to refer patients. So he can at any time refuse to participate in the trajectory of euthanasia. There are 6 rules. So like in Belgium, I think it's unlegal. Euthanasia is illegal unless you follow the rules, and these are the 6 rules that you have to follow to avoid any prosecution, to, I mean, state it in a negative way. So the doctor should be convinced that the request of the patient is voluntary and well considered. The suffering needs to be hopeless and unbearable. The doctor needs to inform the patient about the prospects of the disorder. The doctor has to come to the conviction that there is no reasonable alternative solution for the request, and the doctor has consulted at least one other independent doctor. This has changed a little bit. In case of psychiatry, you need to have 2 psychiatrists to start with euthanasia. If the one who requests is a psychiatrist, you need just another one. If the request comes from a general practitioner, for example, or a non-psychiatrist, you need 2 other psychiatrists to start with euthanasia. And finally, the 6th request is that the doctor should perform assisted suicide with medical care. And you cannot just do anything. You need to comply with the medical care regulation. This is gives you an idea of the general picture in the Netherlands. So we have a population of 17 million people in the Netherlands. Annually, there are 174,000 people who die, and there are 70,900 euthanasia requests in general in the Netherlands. So 4.1% of all deaths are the result of euthanasia, 6,086. And in 30% of the cases, euthanasia is granted. This is, again, general euthanasia. If we look at the psychiatry specifically, we have on average 1 million annual treatments. So at a given moment in 1 year, 1 million people are in treatment for any psychiatric disorder. And we have, lately about 1,100 requests, euthanasia requests in psychiatry. So it's just a very small percentage of the number of patients who are treated for psychiatric disorders. 1% of all euthanasia is devoted to psychiatry. And lately we observed that 60 cases are granted. 60 out of 1,100 requests are really granted. Interestingly, in the Netherlands, so we started in 2002, there is an increase of the requests. So it started in 1995 when they started to measure the requests. There were 320 requests in psychiatry. It went up in 2008 to 500, and the latest measurement, 2016, went up to 1,100. So there's a huge increase. It tripled in 15 years, the number of requests for euthanasia in psychiatry. And another interesting fact is that the willingness of the psychiatrists decreased. Between 1995, there was a 47% willingness of psychiatrists to grant euthanasia, and that decreased in the past 15 years to 37%. So despite the increasing number of requests, the higher number of popularity, there is a less willingness of psychiatrists to perform euthanasia. These are the major, I think, arguments, at least in the Netherlands, regarding euthanasia in psychiatry. The pro arguments is that it's unfair to exclude psychiatric patients if euthanasia is allowed for patients with somatic disorders. The contra argument, on the other hand, is that the criteria for psychiatric disorders are less objective than somatic suffering. Sometimes very difficult to establish the severity of psychiatric suffering, even to establish the disorder. Another argument pro is that psychiatric suffering might be worse than somatic suffering. Mental suffering is maybe harder to objectify, but is no less severe than somatic suffering. The contra argument then is that psychiatric disorders are not life-threatening. Some are to some extent, but most of them are not. Another pro argument is that euthanasia is a dignified medical alternative to patients who otherwise might complete suicide. So it would avoid suicide attempts. And contra argument in the same range is that the distinction between a disorder-related and a suffering-related desire to die is hard to establish. Particularly in patients with major depressive disorder, it's difficult to distinguish whether the request for death is part of the disorder or part of a reaction of a severe patient suffering to the disorder. And then finally, a pro argument is that a lot of people see euthanasia as a part of the responsibility of a psychiatrist. It's part of being a medical doctor, which is a particular perspective on psychiatry, of course. The contra argument in the same range is that some psychiatrists think that it's impossible to grant euthanasia as a psychiatrist because we are contaminated by countertransference ideas towards patients. And then finally, another argument contra euthanasia is that in some cases people doubt whether a request from a psychiatric patient can be considered to be really voluntary and well considered, given the fact that all patients suffer, at least patients with psychiatric disorders, a mental disorder, and per se they are disturbed cognitively and affectively. I will show you some of the data that I got from the Levenseinde Kliniek. Levenseinde Kliniek is an institute in the Netherlands that is responsible for executing euthanasia, particularly in psychiatric patients. We had access to their data, and they recently screened over 3,000 requests. They have put some of the data on their website. They have much more data. I can only show you a part of it. And part of the data I will show you is specifically focused on patients with psychiatric disorders. First, a general slide. So you can see here again that there's a huge increase of requests. In 2010, there were on average 3,316 requests in the Netherlands, and increased to 6,500 in 2017. You can see here the distribution of requests. The majority are requests associated with cancer, with disorders that had to do with aging, dementia, and only a minority in 2017, 83 cases were associated with psychiatric disorders. If you look at this number of requests, and this is based on a group of 1,500 patients, you can see here a distribution of age. It's interesting to see that already at a young age, some people ask for euthanasia. They're, of course, a limited number, but still they're available, or they're still they are present. And even at a very high age, even when people reach an age between 90 and 100, there still are people requesting for euthanasia. The majority are women, 60% versus 40%. And this slide shows you and gives you an idea of the status. So the majority of the people requesting euthanasia with psychiatric disorders are people who have no relationship, are not married, or either divorced or have no partner. So 70% of them live alone, live separate. And this is, I think, an interesting finding, that the people who are requesting for euthanasia maybe suffer as well, being alone, or have difficulties to share their feelings, psychiatric problems, or the request for death. This slide gives you an idea, of the diagnosis, DSM-4 diagnosis, based on a sample of over 1,000 patients. The majority of the patients, as you can see, suffer depression. I'm sorry, it's in Dutch, but I will translate it. So 26% of the patients suffer mood disorders, 9% suffer trauma and stress-related disorders, 9% suffer schizophrenia or psychotic disorders. Then 8% of the patient sample suffer development disorders, 6%, nearly 7% bipolar disorders, and then personality disorders is 5%. It's only a minority of the patients who request euthanasia, at least in the Netherlands, have a personality disorder as the primary disorder. Eating disorders, 3%, anxiety disorders, 2.8%, somatic disorders and related disorders, 2.4%, then personality disorders not otherwise specified, 2.4%, obsessive compulsive disorders, 1%, and then there's a bunch of other personality disorders, 1% and 0.6%. 13% of the patients had no diagnosis. Of course, they had a diagnosis, but it was difficult to assess. If you look at the psychiatric comorbidity, another interesting finding is that most patients have a lot of diagnoses. 80% had 4 diagnoses at least, and I guess that a lot of these extra diagnoses are personality disorders. 22% had 3 diagnoses, and nearly 30% of the patient population had 2 diagnoses. Only a minority of the sample had only 1 diagnosis, 17%. This slide gives you an impression of the requests versus those granted. It starts in 2012, at least this slide. In 2013, we had nearly 300 requests, and minority were granted. And finally, as you can see, in 2018, my guess is that over 60 or 70 were granted out of nearly 700 requests. So it is a very limited number of the patients that really get euthanasia based on psychiatric disorders. A final question that I would like to answer is, why do the requests in the Netherlands rise for euthanasia? There's a huge increase, as I showed you. It tripled in the past 15 years, and there are several, I think, arguments that can explain, or several causes that may explain this rise in requests for euthanasia in psychiatric disorders. Some have to do, I think, with psychiatry. Another bunch of causes have to do with society we live in, and still another one, I think, with philosophy, the way we perceive death and how we look at death in general. So in my opinion, psychiatry has changed, at least in the Netherlands. It's obvious that psychiatry used to be a medical discipline that was focused on mental disorders, but gradually we noticed that in the past 15 years, there is a shift focus from mental disease to mental health. So psychiatrists have become mental health workers, and instead of disease, it somehow moved to health. We do not talk about patients, but about clients. This is popular in the Netherlands, and people talk less about symptoms, but about quality of life. So we use other concepts under other terms, and psychiatry is getting another role, I think, in our society, moved much more from a medical discipline to a social discipline, taking care of the quality of life for clients with the stress on mental health. Another aspect I think that is very important is individualism. I think euthanasia, as we can see, is associated with being alone, being an individual. This map shows you individualism and loneliness in Amsterdam. Amsterdam is a very vivid, interesting city, a very young city, always a very young population, very active, very liberal, but nearly 300,000 of the people living in Amsterdam suffer from loneliness, very interestingly. And these increased numbers of loneliness, I think, are more or less associated with euthanasia and as well requests or attempts for suicide. Particularly now in the corona epidemic, we see rises of suicide going along with rises of loneliness. Another societal aspect, in my opinion, is that the way we perceive life, the way we look at life now, is based on a very capitalistic idea. We see a human as a product. We have to produce just as a human being, and as long as we're productive, we're allowed to live. With the concept of completed life in the Netherlands, there is a kind of idea: if you're not productive anymore, if you cannot find any sense in life, if life has become useless, then you can ask for euthanasia. Then it's more or less finished, and it's a more dignified death if you die just within a medical context, getting euthanasia, than committing suicide, of having no sense anymore in life. This sounds a bit cruel, but I have the impression that a lot of the psychiatric disorders and the way they are expressed now in our society have to do with the image, with the idea, with the norm of a human being as being a product. It's just referring to the same aspect. Life, well, it's a sexually transmitted disease which always ends in death, and there is currently no known cure, so it needs to be very productive. Another aspect I think about the euthanasia and the way how we perceive death is a more philosophical one. Is death really the end of life, or is it the end of life? It's just a game with words. It can be the end in the sense that it's finished life, but it can as well be the goal of life. And for a long time, philosophers have thought about death as giving us a particular goal, as giving us meaning into life. That has changed. I think we see life differently than it used to be, and at least as some philosophers saw it. So getting meaning out of life based on a perspective that death is giving us, because of the fact that it finishes, that it is required to have a meaningful life, is somehow lost. Life means nowadays feeling well, feeling a lot of happiness, and everything that has to do with suffering, that has to do with potential meaning that is related to death, is not accepted anymore. When I speak with my patients, to me it's astonishing that some people do not want to live, but few of them want really to die. One of the remarkable things in the sample that I showed you is that some people requested euthanasia because of social reasons, because they were poor, and offering them money immediately stopped their request for euthanasia. So even if there are psychiatric disorders, still there is as well a large social component, and there's often a mix-up between not wanting to live and wanting to die, which is a really different and other concept. The paradox that I think is very interesting in euthanasia and suicide and any other concept of death in psychiatry in general is that death as a salvation, as an ending of suffering, only has meaning in life. Because if life stops, death has no meaning anymore. So, and that's always the paradox that pops up when we discuss with patients euthanasia and their request for death. This is my final slide. In my opinion, euthanasia is an infinite debate with finite consequences, and therefore we should be very, very careful about granting euthanasia in psychiatry. Thank you.
Thank you very much, Damiaan, for this wonderful insights and your information about numbers in the Netherlands. We now move on. Actually, we move on to more towards personality disorders and also towards the north of Europe. Lars Mehlum is from Oslo in Norway, and he's really well prepared to inform us about interactional aspects or transactional aspects of euthanasia in patients with personality disorder. Let me also briefly introduce Lars. He is the founding director of the National Center for Suicide Research and Prevention at the University of Oslo in Norway. He's a psychiatrist and psychotherapist and had many leader positions on the national and international level. He's currently president of the International Academy of Suicide Research and also a past president of ESSPD, and has acted as an advisor for national suicide preventive strategies for the European Union in numerous countries. So he's now the final presentation, and Lars, the stage is yours.
Thank you, Christian. And well, I've been so fascinated by these presentations we have already heard. So I would be tempted to go on straight ahead and discuss them, but we have one more topic to cover. And my topic for this, let me see if I can go back one slide. I think I was going to go back. My topic is a slightly different topic. It is the transactional aspects of what's happening and going on when a patient asks for and the clinician is granting euthanasia or assisted suicide in people with personality disorders. So, and what do we exactly mean by transaction, and why is this relevant in this context? Well, there are several ways of conceptualizing interpersonal communication, isn't there? Such as a linear one-way communication or an interactional model where there is feedback, two-way communication. The transactional model allows us to think of people building shared meaning in their communication. But there are, of course, many possible ways such a transaction could go awry, and a true and honest shared meaning is not constructed. So for a patient, of course, with a personality disorder requesting and applying for euthanasia or assisted suicide, and the clinician evaluating the legal justification of this request, there may exist several obstacles to such a building of a successful transaction of joint meaning. So I would like to point to some of these challenges according to scientifically and clinically derived knowledge. The core issue here is, of course, the joint clarification of the question of whether the patient's medical situation is desperate enough and entails constant and unbearable physical or psychological suffering due to a severe and incurable illness, which cannot be alleviated. And the patient needs then to be perceived as untreatable, as we have heard, or uncurable. And this perception will, in the case of mental disorders and mental suffering, be based on both the patient and the clinician perceiving the situation and how they transact. So this is my problem, of course. You would think perhaps that clinicians, in the context of assessing the justification of a request for euthanasia or assisted suicide, would need to be acting or maintaining a very objective and rational position. Well, however, this is not that easy in the case of people with personality disorder, particularly borderline personality disorder. We have countless evidences and testimonies on the pain most people with borderline personality disorder are feeling, such as this quote from Marsha Linehan. People with borderline personality are like people with 3-degree burns over their 90% of their bodies. So lacking emotional skin, they feel agony at the slightest touch or movement. This is quite a graphical way of putting it, isn't it? So when interacting with other people, people are really feeling a lot of pain. And of course, we know then that people or clinicians often find it very hard to work with those clients, since being close to someone who is in such strong emotional pain without apparently being able to alleviate their suffering is very difficult. Well, I would like to cite the very well-known American psychiatrist Alan Francis, who once wrote, and this is the quote, "Of all disturbing behaviors, self-mutilation is the most difficult for clinicians to understand and treat. Most of us have a much greater immediate empathy for a patient's depression or anxiety, and even for violent impulses and psychotic thinking, than we do for the relief some patients feel when they hurt and scar themselves. Typical clinician, myself included, treating a patient who self-mutilates is often left feeling some combination of helpless, horrified, guilty, furious, betrayed, disgusted, and sad." And of course, this is just one aspect of personality disorder, and particularly borderline personality disorder. But those of you who are very well experienced with treating them, you know what I'm talking about, because this is sometimes, or quite often, evoking some combination of helpless, horrified, guilty, furious, betrayed, disgusted, and sad. These are emotions that can make even the best clinician less capable of thinking and responding rationally or clearly, acting in what we would think would be in the best interest of the patient, right? So what about the patient and the client in this dyad? What could influence the patient's perceptions and process information and act in our best interest? Well, what could influence the patient's side here? We know that people who are suicidal and hopeless have more negative views of themselves and the world. So people with borderline personality disorder, they have a pattern of thinking more often about suicide and death than others. And this thinking becomes gradually a negatively reinforced behavioral pattern. It's an escape route from emotional pain very often. This happens primarily in the mind of the patient, but commonly it may also play out in the communication with other people, such as therapists, of course. We know also that people with who are suicidal have more problems with accurately processing information. They are more selective in their way of interpreting events and circumstances in their lives, and they have difficulties generating thoughts about what could possibly happen in the future that could change their conditions. They have more a strong inability to generate thoughts or beliefs that the pain will eventually become less severe or disappear. And they have often a lack of ability to envision themselves successfully coping with problems and difficulties. They may also have a stronger lack of confidence in other people's willingness and or ability to help mitigate the pain. So these are quite a few dispositions that are more prominent among suicidal and or hopeless people. And I wanted to highlight this model here, namely when this lack of ability to envision that things might get better coincides with the belief that there is no way I can get out of this or to escape. And I have no control over my current situation. I may easily feel checkmate. A state of entrapment is established. The wish for death is very often linked to this state of entrapment. The person feels this is the only remaining way out. So to die, to request for euthanasia could be very relevant in this entrapped situation, or of course suicide. Now, hope and hopelessness is very often thought of in philosophical terms. But if we leave the philosophical or philosophy for a moment, we could define hopelessness as a lack of ability to produce pathways to achieve desired goals and motivate oneself to use those pathways. That's one way of defining in a more behavioral way or cognitive way hopelessness. And on the other hand, we could define hope as a cognitive skill, which we can strengthen through treatment or through psychotherapy. Just to give you an empirical example, because this is really important, I think. If we leave the philosophical way of conceptualization and think of it in more therapeutic terms, which is actually evidence-based, we could think of many ways we could utilize this in treatment. And I wanted to give you an empirical example of how you can use this. So this is from a study of young people we had in treatment, people with borderline personality disorder and repetitive suicidal behavior, who had high levels of hopelessness when entering the treatment in this randomized trial. During the intensive treatment of only 19 weeks, we worked hard to change this hopelessness, among other treatment targets. And what is shown in this figure is that the more the level of hopelessness was reduced in the patients over the 19 weeks of treatment, the less suicidal these young people were, both at the end of treatment and at even 3 years later. And the change in hopelessness was actually the mediator of the reduction in suicidality. So my point is that to treat hopelessness and suicidal people with borderline personality disorder is by no means a hopeless endeavor. It's actually something that is empirically validated. Now, of course, people with borderline personality disorder is not only, as if that was not enough, very often self-harming and suicidal. They are very often also emotionally dysregulated. This is actually a disorder of emotion failure. So the emotion dysregulation encompasses both the personal experience of emotion and recognition of emotion in others, and this failure to describe what goes on in your own mind, and it's linked to unhappiness, has actually been known for millennia. This is just a quote from the pretty well-known emperor Marcus Aurelius. Now, the statement says, through not observing what is in the mind of another, a man has seldom been seen to be unhappy. But those who do not observe the movements of their own minds must of necessity be unhappy. Well, I would tend to disagree with Marcus Aurelius, because I think both it is important to know what's going on in your own mind, but also what's going on through mentalization in other people's minds. So this is well-known principles. And we know that people with a borderline personality disorder have biased responses to neutral or ambiguous facial expressions in others. They don't only are poor in reading people's minds, but also their faces and interpreting the results. They have more dichotomous thinking. They have more difficulties in using contextual information accurately to improve social cognitive tasks, more social problem difficulties, and more negative expectations of how they will be treated by other people. I mention these difficulties as a backdrop to understand the difficulties these patients may have when entering a transactional process necessary to engage in working a relation with a therapist based on communication of needs, resources, attitudes, and values. If we then add the profound asymmetry of the relationship between patient and clinician, it becomes really challenging. Here you can see some of those things making this very asymmetrical. The clinician's level of knowledge, of course, the clinician's job for which she is being salaried. This is a job, not a whole life. The clinician is usually more healthy. The treatment session playing a comparatively much less prominent part of the clinician's life. clinical environment much more familiar to and in control of clinician than patient, and many more things making this very, very different. And of course, the task of any clinician would be to make the relationship less asymmetrical, right? But this is another topic. This is a process then to work with the patient to establish a working relationship, which you cannot do without when treating patients with personality disorder. But of course, this is really challenging, and it's not for the faint of heart. And it explains perhaps more why so many of these patients drop out of treatment at an early stage and eventually become regarded and regard themselves as untreatable and incurable. Well, I tried through what I've been mentioning so far in my talk. I wanted to highlight that the notion an expert or clinician may have of the patient as untreatable and incurable may arise from a failure to understand and to see this patient's core problems. And I was thinking of this quote from the wise Icelandic author Jon Paul Nanskjøtansson in this context. So from this book, The Sorrow of Angel, he says, this is how it is. Sometimes you cannot see what things are until you get really close up, and therefore we should never judge things from a distance. This is one perspective. You really get to get close. You need to get closer to actually be able to assess the patient with personality disorder as untreatable and incurable. It requires really an intimate knowledge of this person and contemporary treatment methods and what they really have to offer these days. So we need to get closer, but we also need sometimes to see the larger picture. I was thinking here of the well-known Russian author Euthanasia and this quote, "Man is like a novel. One doesn't know until the very last page how the thing will end." So I think it's quite suitable to describe how little we sometimes know about the prospects of someone else. I've had the privilege over my career to do several follow-up studies of people treated for personality disorders. I remember one woman I followed up, interviewed several years after her treatment. This was actually more than 30 years ago, and prospects were very poor at that time for people with her disorder. And I traveled to her place of residence to see her. And she had moved abroad to Sweden.
Lars, sorry,
yes?
Sorry, there came a message from the audience. You are difficult to understand. Probably your papers are hiding the microphone. Is that possible? Because we hear the papers shuffling a bit.
Okay.
Maybe
that was.
Now it's better.
Is better? Okay.
Yeah, much better. Yeah.
Okay.
But thanks.
Okay. So this is actually very close to my ending of this talk because I wanted to share this story about this former patient, and I traveled to her place of residence, and that was actually in another country. She had moved to Sweden to this wonderful manor house, which you can see in this picture. And lo and behold, she was actually, literally speaking, the lady of the manor, and she was happy. And through my 3 to 4 hour interview, I could clearly document that her life and the quality of life had improved dramatically. It really taught me a lesson, I think. I had never expected this outcome in this patient because it was really a poor prospect. But I think the lesson is worth conveying to all of you also in this context. So man is really like a novel. One doesn't know until the very last page how the thing will end. Therefore, I'm deeply skeptical to making very clear assessments or very clear predictions about the futility and the prospect of patients with personality disorder in particular. And I do think that we need more research. We need more research into what are actually the transactional nature and what's going on when we are both receiving requests for euthanasia and when we are dealing with these requests, what's going on here, and what are the impacts on the assessments we are making before we proceed. Because I think we are a little out of control when it comes to this particular group of patients. There are several parts of the literature we have reviewed that seems to indicate that the more knowledge clinicians have when they are conducting or recommending euthanasia, the less they are inclined to grant people with personality disorder and psychiatric disorder euthanasia in the end. So I think I'll stop there. I hope you could hear most of what I said. If not, you might ask me some questions. Thank you.
Thank you, Lars, very much. I think we could understand, we were able to understand nearly all of it. I would now ask the other panelists to also join and to switch on their camera so that we can start the discussion. Okay, so welcome back. And we start with the questions from the audience, actually. First, there was a general question, and I just wanted to mention that again, that the presentations and the whole webinar has been recorded, and the recording will be made available through the ESSPD website in a couple of days. Okay, so now we come to the particular questions. The first question to Joris is there a connection between the number of suicides of psychiatric patients and the possibility for euthanasia? And does euthanasia bring the number of suicides down? That's a very interesting question.
Well, there's certainly no data that would support that, and I honestly wouldn't expect it either, because I think we're talking about two very different populations. I think if we look at the patients who die from suicide and have a psychiatric condition, I think that there's a very, very small minority of them who would qualify for euthanasia. I think we know about psychological autopsy studies that most of those patients, a very large majority of those patients, do have treatment possibilities, would never qualify for euthanasia. So I think that if there is a subgroup where we could say that it's a matter of rational suicidality, and where there will all treatment options have been tried, then you could argue that maybe there euthanasia might be an alternative. But if we just look at the figures, I think in Belgium there are about 50 times more suicides than there are euthanasias for psychiatric reasons. So this is a complete other kind of numbers, and I think it is a quite different group of patients as well, with very small overlap. So it would be an illusion to think that with those small numbers we could influence a large group. That's on a group level. I think on an individual level, I think, and I see in patients, that it could help them to fight suicidal ideation. Knowing that they are heard in their euthanasia request and it is taken seriously can help them to fight suicidal ideation. But I doubt whether that could really influence the figures on the group level.
Mm-hmm. Okay, any comments from the other presenters on that in the Netherlands?
Yeah, I think there are some cases where patients who got rejected commit suicide. So there is a link. Of course, there are two different populations in proportion and in request, but in some cases, if they get rejected, people commit suicide.
Mm-hmm.
I could perhaps also comment that I do recognize the lack of studies, so that is the big problem, but I could clearly envision that people who have a feeling that they have gained a certain control over their destiny would actually be less inclined to commit suicide if they felt that they could always exit this world via euthanasia. Of course, we don't really know this, but I could clearly think that that would be the case. And these are some of the paradoxes sometimes, apparent paradoxes that these are linked, but they are not directly overlapping populations, right?
I think I read that in Joris, in your one of your papers, that in several cases, once euthanasia was granted, then the patients went back and said, I want to live and I don't want to have it executed. So this seems to be not a small proportion, right?
Yes, I agree. It's really something we clinically encounter often, that people sometimes even go through the whole procedure and they get their file ready, as they tell me. And they have their two positive advices. They have someone who is prepared to perform euthanasia. And at that point, you often see weird things happening. You see that that patients, knowing that there is a possibility made concrete of euthanasia, that the fact of this possibility really changes things for them. And they say, well, now I know we have this escape route, we have this emergency exit, and that helps me to carry on. So it's a very tricky thing, because in fact it raises a lot of questions, and maybe it was not that without prospect. Maybe there was some prospect, but the only prospect made concrete was the opportunity and the possibility of euthanasia. So that are one of the paradoxes you really can get entangled in euthanasia requests.
It will probably also speak to the very strong need of control, right? That what people, quite a lot of people, really lack is a sense of control over their life. And that can be gained in several ways. And I'm sure that if you know that you can always ask for and get euthanasia, that can create a certain level of control.
Okay, I think we have to move on because there are a couple of questions coming in. Another question again for Joris. I'm wondering what happens in Belgium if a family member refuses to agree with the decision for euthanasia.
Well, there's no consent needed of family members, none whatsoever. So this is really a decision of the patient. The law even says that you don't have to involve family members. The guidelines tell us that you have to, in one way or another, you have to involve them, not to ask their permission. And I think that it would even be cruel to ask their permission. You can never ask a family member whether they would agree or grant a euthanasia request. But to be involved and to at least get the chance to prepare, to give their reactions, to maybe reach out to the person in question and to try to re-establish or reconnect with the patient. So the whole idea of involving the patient, the family members of the patient, is not to get their confirmation or their consent, but just to get them involved and to try to move things. And actually, the involvement of family members, I think, is one of the most powerful elements in the evaluation procedure. And more than once I've seen that the involvement of family and the reactions of family and the things that happen then, if they are told about the death wish of their family member and the whole sequence that is set into motion by that event, can really change things for the better, and can sometimes be one of the crucial elements that makes that you end up somewhere completely different than in the euthanasia trajectory.
Okay. Maybe Damiaan, do you want to comment on the situation in the Netherlands? There's also no obligation to involve the family.
No, there is no obligation to involve the family, but often they are involved, of course, and I think it's helpful for the process. Yeah, and sometimes we have seen very annoying and displeasing conversations when we discuss euthanasia. In case that family members do disagree, we always invite them, have the discussions, but they may be very conflictuous.
Okay. Now the next question, I think it's for all of you panelists. Is there any research on the criteria that psychiatrists rely on if they confirm to untreatability and alleviation of a psychiatric disorder? Who wants to start? Maybe Damiaan, you. Start with the Netherlands this time.
Yeah.
Any research on the criteria that psychiatrists rely on if they confirm to untreatability?
If they confirm the what? Sorry,
confirm to untreatability.
Okay, that's a matter of discussion, in my opinion. That's why we have as well two psychiatrists. So we have one separate psychiatrist to confirm the diagnosis and another one to confirm treatment refractoriness. We see often different opinion in terms of untreatability between therapists, between, of course, the patient and the therapist often. And both have different ideas about untreatability. What means untreatability? Sometimes a psychiatrist thinks that there are still treatment options, whereas a patient completely disagree. And that has to do with the criteria in terms of response. If you look from a very medical perspective, there might still be a treatment option, but from the perspective of the quality of life, patients may have completely different opinions. So I think it's a very good question, a crucial aspect that particularly in psychiatry, there are no hard criteria regarding untreatability, and that offers a lot of discussions.
Mm-hmm. Thank you. Joris, you want to comment?
Yes, if you look at the guidelines, there's a huge dependence on the specific treatment guidelines. So the whole idea is to start from a good diagnosis, and often in the process of an evaluation of euthanasia request, that is a problem. Often we notice that there is no formal diagnostic procedure, and we have to start there. We have to establish diagnosis, and especially in comorbidity, that is difficult to do so. So often there is a diagnostic procedure. And then the idea is that you have to rely on the relevant treatment guidelines for those diagnoses that were established in the patient. And the idea is that you can only proceed with euthanasia if all the evidence-based treatments of all the guidelines for the diagnosis involved have been tried in a state-of-art manner. But that is theory, and we have to say that in practice there is some research actually, because that was a question. There's some research. I'm thinking about research group of Scott Kim, American psychiatrist and ethicist, who has been doing some research, especially looking at the Dutch data and looking at the difference between theory and practice. So this is what we claim in theory, but in practice, for instance, and in Belgium, just as in the Netherlands, we are aware of cases where, for instance, for unipolar depression, electroconvulsive therapy has not been tried, which is, I think, at least controversial. To establish that it's irremediable if you haven't tried one of the most efficient treatments available. So I think we have to move. There's still a gap between what we say that should be a theory in establishing irremediability and what is done in practice, with a huge variability in the different euthanasia cases.
Mm-hmm. Okay, thank you. Lars had a question or a comment?
Yeah, well, I think we have arrived to a very, very important thing here, because isn't it really fascinating that you expect in those countries who have established this as a legal practice, that you really expect that a few selected, might be very highly reputed and esteemed colleagues are nevertheless expected to be able to have a sound overview of the whole entire and very complex field of evidence-based practices. We are not only talking about overview of all treatment guidelines, but also of all of that is behind guidelines. We know that it might take a couple of decades before guidelines are actually updated or established in the field of practice, right? In psychiatry, for example, and many countries in Europe and many countries but don't even have guidelines for major patient groups in psychiatry, and some of them are very poor and they are not updated. So what we really need to have is here to have clinicians who are super experts, and not only on these treatments, which are hundreds of treatments, but also on the response rates and the individual needs for patients within these broad groups of, personality disorders are, for example, a very complex and heterogeneous group of patients. So I think this is really very difficult to envision that can be expected from even very good clinicians.
Well, maybe I want to add that it is not unusual if a patient has a euthanasia request and is evaluated that a lot of people are involved actually. According to the law, at least 3 people have to be involved. The one who is willing to execute euthanasia and 2 physicians giving advice. Often there is a treating psychiatrist involved, a general practitioner, but as is proposed in the guidelines, you have to involve a specialist in the disorder at stake. So if I see a patient with a borderline personality disorder requesting euthanasia, I want to have the advice of a colleague that is specialized in the treatment of personality disorders. So you really get the expertise. It's not just a theoretical exercise looking at the guidelines. No, you also want the experts in the field who have experience with the diagnosis at stake, who can look at the case and think about it and discuss it and give advice on what is still a good treatment, a reasonable treatment option.
Okay, thank you. I'm sorry to interrupt you, but there are a couple of other questions I would from the audience. The next, I think, also a very interesting and important question: can psychologists be included in the processes in the Netherlands or Belgium, or only psychiatrists? Who wants to start, Joris or Damiaan?
Yeah, to be short, of course they can be involved, but the formal final advice has to be from a psychiatrist. But often he collaborates with psychologists. Well, just recently I've sent a patient of mine requesting euthanasia to a psychologist who is a specialist in trauma therapy, because I wanted his advice on the treatment options that might still be there. So they certainly can be involved, but you always have to have the
formal role.
The formal advice has to come from a psychiatrist who can integrate all the information available from different specialties.
Okay, Damiaan, same in the Netherlands?
It's the same. I think it's a medical act. And therefore it should be a doctor. Of course, they can be involved, but if eventually you need a psychiatrist to either decide or execute.
Okay, thank you. Next question to all of us, I guess. Does the patient has a right to reject a treatment like ECT? Is there a right to force patients for a therapy? No.
Well,
no.
I mean, so the question, for
that's
example,
the whole issue. Yeah. So we are a center for deep brain stimulation, and we often have these discussions that we think that DBS is an option or adaptation of DBS that a patient refuses. And that's what I mean with untreatability as well. So it's not a very strict criterion. If they refuse to follow that treatment, then well, and in the Netherlands, if they find a general practitioner and another psychiatrist complying with their idea, they can go for euthanasia, despite the fact that I, as an expert, have advised contra.
Okay, Joris?
Of course, there can never be an obligation to take to follow one or another treatment. But at the other hand, there's never an obligation for the physician involved to continue with giving advice on euthanasia or playing a role in euthanasia. So what often happens is that you explain to patients that they have the right to refuse a certain treatment, but that the consequence of that refusal is that I cannot play a role or give a positive advice in their euthanasia evaluation, and that probably most of the colleagues I know would say the same. So the consequence of their refusal would be that if it is an established treatment, evidence-based and relevant for the disease or the disorder in question, well, the consequence is that the criterion is not fulfilled and that euthanasia is not a possibility, with, of course, the differences in the interpretation from the different clinicians involved. Maybe some psychiatrists may say that it's not necessary to take that treatment.
Yeah, maybe coming back to the question of treatment guidelines. So there is no checklist like you have to fulfill the algorithm of like ECT in treatment-resistant depression before it can be granted. That's right. So, but this is that something that is being discussed? Like Joris, you are advocating for a procedure that is a committee that is assessing that before it is granted. Is that something that is discussed?
Well, at this moment, the only evaluation that takes place externally, not by the people who are involved, is the evaluation after the patient has died.
Right.
That's what happens now. And the logic of that is that the large majority of patients, of course, is in a terminal phase of their illness, that waiting till there is an evaluation would be unethical, I think, because that would mean that the patient is suffering for some more days or even weeks just because they have to wait for the advice. But in all patients who are not in that terminal phase, I think that it would be reasonable to have an evaluation in advance. That is not the case now in the Belgium system, but I think that would be reasonable that you have a committee-based evaluation in advance, looking at those aspects, and not just a few clinicians involved. You can broaden the base with involving more clinicians, but then again, looking with a committee with a bit more distance and with certain guidelines that are checked would be, I think, for something so important and so irreversible as ending the life of a patient would be the preferable way to go.
Yeah. Is that something that is discussed in other countries as well, in the Netherlands? Like moving this decision before it is conducted, to have a committee or an ethics panel deciding? Is that a discussion that is only in the Netherlands?
Well, in practice, the big problem in the Netherlands is that despite the fact that euthanasia is well, it's possible, it's legal, only a few psychiatrists are willing to execute it. And that's a big issue in the Netherlands. So we have this separate institute, it's called the Levensende Kliniek, and they perform 80 to 90% of the euthanasias in psychiatric patients. They are specially designed to assess patients. So the procedure in the Netherlands is often very complicated. You go to your regular psychiatrist with a general practitioner or someone else, and they will discuss it. And in any case, most psychiatrists will refer a patient to this Levensende Kliniek, which is this external institute, and they will restart with the whole process, with admittance and discussions and so on. So in the end, it's very sophisticated, which is a good thing because it raises the bar, and it has something to do with the fact that psychiatrists are reluctant to execute euthanasia. But there's a lot of criticism. A lot of people think that psychiatrists should be much more involved and actually perform euthanasia, like general practitioners do.
Mm-hmm. Okay, thank you. There's another question for Lars this time. What do you think about asking people who have survived and lived through PPD and ask whether they are glad they didn't commit suicide or get euthanasia? It's more a suggestion of informing. Yeah.
I don't know what the purpose would be, but I would think that we should ask these questions, what if questions, more often when we are following up on patients who have been in treatment before. For example, in our research studies, we should ask questions like this because sometimes we get surprising answers. But I don't know what the person who asked the question felt would be the use of asking it. It could, of course, be important for people who are contemplating asking for and getting euthanasia instead of getting more treatment. It could be helping them to try another time, because that is probably what we who are dedicated to treating people with personality disorder is very often seeing in our patients, that people have been giving up on them and they have been giving up on themselves, and they quit trying and they give up on treatment, which is really part of a huge psychoeducation task, I think, that we need to get more information out there to the public, particularly in the situation Joris and Damiaan is describing, that the society has changed and that people are perhaps viewing mental health as a more materialistic way instead of a personal project of hope and surviving in this society. I would think that that could be useful to have some help from people who have survived.
Okay, thank you. These are, I think, ideal words to come to the end, and I see Babette reappearing. So that means we are already at 6 Central European time, and the 2 hours went by very fast. I personally enjoyed it a lot, and it was very interesting, and I hope the audience also enjoyed it. I apologize that we probably couldn't answer all the questions, but I assume that if there are remaining questions to individuals of us, including me, just send us an email and we will be happy to answer those. And again, we will make available the presentations later. Babette, you want to say the
Yes,
last
thank
final
you.
word?
First of all, I want to thank all of you for your presentation, and also our audience for asking the questions. And Christian is completely right. There are many more questions we cannot answer during our time. But let me say that I am really very happy and content with this discussion. I think it is a very difficult issue, controversial, but I also appreciate your input. I learned a lot, and I hope that everybody who joined us today did it the same way. We will save the questions and respond later on by email. And now for everybody, have a very good evening and hopefully a good week, and see you probably next time during another webinar, and feel free to send us feedback. Thank you very much.
Thank you. Can we stay?